Good morning, everyone. Welcome to our 8th conference. I think we have a great lineup of talks today. And we're really focusing on outcomes and how we can improve outcomes in orthopedics and how we're already doing that. And pediatric ACL injuries are a great topic for that. So we see a lot of ACL injuries in young athletes. And that age is getting younger and younger as we're seeing younger kids participate more intensely in sports, year-round sports, and single sports. The treatment is different than in the adult. In the adult, you're trying to stabilize the knee. The ACL is a ligament that helps stabilize it. In the pediatric population, you have to worry about stabilizing the knee and protecting their growth plate so you don't injure or inhibit the growth of their leg. So when you look at the knee, the ACL is the ligament in the middle of the knee, and that is this right here, and that helps stabilize the knee. So when, again, we look at the pediatric population, the difference is we're worried about the growth plate, or we need to protect that in the younger age group. And the growth plate is right here in the femur and right here in the tibia. And when we reconstruct the ACL in an adult population, you cross that area with drill holes that can potentially injure the growth plate. And so in the pediatric population, we need to be focused on that and make sure that we're not injuring them, we're giving them the stability that they need, but that we're not causing any damage. So here's a video that just shows the function of the ACL. Let's see if that'll work. So what it shows is that the ACL stabilizes the femur on the tibia when you go through a range of motion. It stabilizes both front to back and with pivoting or rotational stability. So it's a very important ligament, and the reason it's so important is if you lose that stability of your knee, you are at risk of injuring the meniscus and the cartilage in the knee, and that can lead to arthritis at a young age. So that stability is really important for the young athlete. So when we look at the population of pediatrics, of kids, there are also different injuries that they may have than the adult population. So they may have a regular full ACL rupture that we see in the adults. They may also have a tibial avulsion fracture, and that is where you actually see a piece of bone pull off from the tibia when the ACL gets injured rather than a rupture of the ligament itself. You can see a partial tear of the ACL, which is seen in this MRI here, where part of the ligament is injured, and then you can see a full ACL rupture where the entire ligament is gone. And the treatment options are different based on the injury pattern. So how do these injuries occur? Similar mechanism that we see in the adult population. It's often a pivoting with the foot planted. It's usually non-contact, so it does not need to be a football player, it doesn't need to be a hockey player. We see it in a lot of non-contact athletes. Again, it's the foot's planted, your knee can be flexed. It can also be in a hyperextended valgus position where your knee drops in. Often kids will complain of feeling a pop. They cannot continue to play for the most part, so it's not going to be the kid who injures their knee, continues the game, and comes off the field and says, my knee hurts. That's for the most part. Sometimes there's variation. And then often the knee will swell up after the injury. So when a child comes into the office and says, I hurt my knee, those are the things that we may be listening for to determine if it is an ACL. And here's another video, and we're going to see an athlete come on to the field, plant her right leg, and right there, feel that pop and that ACL is injured. And that's a slightly older athlete, but it gives you an example. So when an athlete comes into the office, we're going to look at a few different things. The first thing is the history. We're going to listen to what happened. It's a little bit harder in kids. They don't often remember. Maybe their parents were on the sidelines and saw it, but maybe they weren't. So the history sometimes can be more challenging, but often they'll describe instability and a pop. That can be an ACL. It can also be an injury to the kneecap, a dislocation of the kneecap. So you have to take all those different pieces of the history and put it together. The second thing we'll look at are the x-rays, and we'll look at those in the office. We'll make sure there are no fractures, and we'll look for things like the fracture, the tibial eminence fracture, where you can see that on an x-ray. The MRI we try to use to confirm the ACL injury. In a kid, oftentimes that is very helpful because the exam or the history may not be as clear. So here's an MRI looking at a normal ACL. In this second picture on the right, there's no ACL there. So that would help us confirm that diagnosis that this child has an ACL injury. The treatment decisions, again, are going to be dependent upon what that injury is. Is this a tibial avulsion injury where there's actually a fracture? Is this a partial ACL tear or a full tear? In the avulsions, if that piece of bone is broken off but it really hasn't moved much, then we can treat those non-operatively. If it's moved out of position, we will have to put that piece back in surgically and fix that. If there's a partial tear, we have to look at how much of a tear is it. Is it 10% torn or 90% torn or somewhere in between? And is the child unstable on exam? Again, that instability can lead to other injuries down the road. If you put that kid back on the field with an unstable knee, they can have an injury to the meniscus and the cartilage, and that can lead to early arthritis, and we certainly don't want that to happen in our young athletes. If it's a full tear, we still need to think about, in the young child, do we want to treat this with surgery or not, or non-operatively? And that really goes down to their age, the stability of the knee, and really looking at the growth plate. So the growth plate is so crucial in these kids, and if we have a 9 or an 8-year-old come in, they have a wide open growth plate, and if we injure that growth plate, then we can really impair the healing of their femur or their tibia by drilling across. So when we do decide on surgery, our goal is to recreate stability and protect the growth plate. Non-operatively, you can delay sometimes. We see some of these really young kids, we're worried about their growth plate, they may be very young in terms of maturity. We may start treating them non-operatively with a brace, rest them, do physical therapy. They generally are not going to get back to that contact cutting sport to begin with. We're going to have them use the brace while walking. But usually they're not going to get back to a cutting sport until you do that reconstructive surgery because their knee is going to be unstable. Most of these children have a difficult time, again, getting back to sport until you reconstruct them. If they have recurrent episodes, even just walking around with that unstable knee, they are at risk of having injuries to the meniscus and cartilage. So we're pretty cautious about treating these kids, reconstructing them as soon as possible so that they don't have further injury to the knee. The goals operatively are, again, to stabilize the knee and to protect that growth plate. And that really depends on how old the child is. If they are 8 years old and their growth plate's wide open, we probably want to avoid the growth plate entirely. If they're 14 years old and their growth plate is almost closing and they don't have a lot of growth, you can treat them more like an adult. And then there's a lot of children who are in between that, and we need to do, we may do a combination of protecting the growth plate, maybe avoiding it entirely, or going through it in a very sort of protective way. The type of graft that we use. In kids, we generally will not use a bone plug. We'll use entirely soft tissue. We know that that's more safe for the growth plate. How we drill the tunnel. We want to be more vertical, smaller tunnels, and again, that is less dangerous, has less of an impact on the growth plate. So those are all the things that we're thinking about in the pediatric population that we're not worried about in the adults. So when we look at the different techniques, and I'll show you some pictures of these, again, we can entirely avoid the growth plate, and that can be challenging. There's not a lot of space there, and so you're going to change the direction of your tunnel. You're going to go in a small space right here. So if this is looking at a knee, normally in the adult population, you would drill right across here, and in the adult, that growth plate is closed, so you're just drilling across bone, and then you would drill across here as well and go across. In the pediatric population, in a really younger child where we really don't want to impact that growth plate, we'll avoid it entirely. So you can do a small tunnel here and a small tunnel here. You can go entirely outside of the joint and go around it as well. If a child is closer to maturity and you're less worried, maybe they're 12, their growth plates have not entirely closed, but they're getting close to that process, you can drill across the growth plate in the tibia and then try to avoid it on the femur. So there are a lot of techniques where we'll do a combination depending, again, on the child's age, how big they are, and the maturity of the growth plate. When we use a soft tissue graft, and often we definitely use their own tissue, and often we use a hamstring, we're going to pull that graft. This is pulling it right into the joint. And that's an example of pulling that graft right in. And again, where we drill those tunnels can differ depending on the age and the maturity of the growth plates. And this is just checking that ACL. So this is a new ACL for this young athlete, and it will give them stability as they go through a range of motion, both front to back and a rotational stability. So current recommendations vary, again, depending on the maturity of the athlete, depending on the growth plate. For the most part, these children do better fixing the ACL, reconstructing. We can't, for the most part, repair it unless it's the fracture. But reconstructing that ACL at a younger age. And that really, again, prevents against injury to the cartilage and the meniscus. We want to protect the growth plate, so that can be a combination of entirely avoiding that growth plate or going through it in a very safe way where we drill a vertical tunnel, use a soft tissue graft. We also don't want to have any hardware going across a growth plate, so we avoid using a screw that may go across it and stunt the growth of the growth plate. And we've made a lot of these advancements that have really improved the outcomes of our young athletes who can get back to sport faster. We're not seeing the same arthritis that we did in kids in the past who maybe did not have that ACL reconstructed, had further injury to the knee, and developed arthritis younger. So we've made a lot of advancements, and it's really exciting. For me, the biggest advancement that we can make is on the next one is really preventing these ACL injuries. And so we've done a really tremendous job surgically coming up with new techniques to protect the growth plate, to get our kids back out on the field safely, and that is really important for these athletes. But the probably more important thing that we can do is prevent them from happening in the first place. And that's probably from an outcome standpoint, the next step that we need to introduce into the schools, young sports teams, travel teams, is ACL prevention programs, where we can teach our young athletes, males, females, the exercises that will help prevent these injuries from occurring in the first place, so that we don't even have to go down that route of introducing them to surgery and the timeout from sport. So thank you very much.